In emergency medicine, the cases that stay with you are rarely the dramatic ones. The dramatic ones follow a logic you can trace: the accident, the acute event, the clear and obvious cause. What stays with you are the quiet ones. The 61-year-old woman admitted at 2 a.m. with a hypertensive crisis whose blood pressure had been climbing for years while she slept, entirely unaware. The 55-year-old man whose kidneys were failing not because of anything that had happened to him suddenly, but because of something that had been happening to him every single night for a decade. Not a disease process in the conventional sense. Not a dietary failure or a sedentary lifestyle or a genetic misfortune. A habit. One specific nightly habit, or rather the absence of one, that had been quietly dismantling his cardiovascular system in the hours when he believed his body was simply resting. The habit I am going to describe today is not a supplement. It is not a breathing technique promoted on wellness platforms or a cold plunge protocol favored by biohackers. It is something supported by a substantial and growing body of peer-reviewed cardiovascular research, recommended in various forms by major hypertension guidelines, and practiced in consistent form by people who tend, as a group, to have measurably better blood pressure control, lower rates of cardiovascular events, and longer lives. It happens at night, which is precisely why most people have never connected it to their blood pressure. And the mechanism by which it works reaches deep into the biology of how the cardiovascular system repairs itself or fails to during the hours of sleep. To understand why this matters and why it works at the level it does, we first need to talk about what the cardiovascular system is actually supposed to be doing while you sleep. Because most people think of sleep as a passive state. The body powers down, the brain consolidates memories, and you wake up restored. That picture is incomplete in a way that turns out to be clinically very important. Sleep is not a passive state for the heart and blood vessels. It is an active, highly organized period of cardiovascular repair and regulation that follows a precise biological program. In healthy sleep, blood pressure drops by 10 to 20% during the night, a phenomenon called nocturnal dipping. This dip is not incidental, it is physiologically essential. During this period of reduced pressure, the endothelium, the thin cellular lining of every blood vessel in the body, undergoes repair processes that cannot occur efficiently under the mechanical stress of daytime blood pressure levels. Inflammatory markers fall. The parasympathetic nervous system, which governs rest, recovery, and cellular repair, takes over from the sympathetic system that dominates waking life. Cortisol drops to its daily minimum. The renin-angiotensin-aldosterone system, which regulates blood pressure through fluid and sodium balance, recalibrates. This is, in the most literal biological sense, when your cardiovascular system services itself. And the quality of that service depends almost entirely on the quality of the sleep in which it occurs. Research published in the European Heart Journal has shown that individuals who fail to exhibit normal nocturnal blood pressure, dipping so-called non-dippers, have significantly elevated rates of cardiovascular events, target organ damage, and cardiovascular mortality compared to individuals whose blood pressure dips normally during sleep, even when daytime blood pressure levels between the two groups are comparable. The night matters independently. What happens to your blood pressure while you sleep is not simply a reflection of your daytime cardiovascular health. It is a determinant of it. This is the biological context in which the night habit operates. It does not lower blood pressure through a single mechanism. It lowers blood pressure by restoring and deepening the nocturnal cardiovascular environment that the body requires to repair itself, an environment that the majority of adults in the modern world are systematically degrading without realizing it, night after night. The habit is consistent, sufficient, high-quality sleep, pursued with the same deliberateness and structural attention that most health-conscious people already apply to diet and exercise, but almost never apply to sleep. And before that sounds like a restatement of obvious advice you have heard before, I want to be precise about what the research actually shows, because the mechanism here is considerably more specific and considerably more impressive than the general recommendation to get more rest. A study published in the journal Sleep, involving over 4,000 adults, found that individuals who consistently slept fewer than 6 hours per night had a significantly elevated risk of hypertension, compared to those sleeping 7 to 8 hours, independent of body weight, physical activity, salt intake, alcohol consumption, and smoking status. The sleep deprivation was the independent variable. The blood pressure elevation was the measurable consequence. But what is more important than the association itself is the mechanism, because the mechanism explains not just why sleep deprivation raises blood pressure, but precisely what happens inside the body during insufficient sleep that drives that elevation, and therefore what is reversed when sleep is restored and optimized. When sleep is insufficient or fragmented, several converging biological processes push blood pressure upwards simultaneously. Sympathetic nervous system activity, which should be substantially suppressed during sleep, remains elevated. Cortisol, which should reach its daily nadir during the early hours of sleep, does not fall as far or remain suppressed for as long. The renin-angiotensin-aldosterone system, which regulates blood volume and vascular tone, becomes dysregulated in ways that favor sodium retention and vasoconstriction. Inflammatory cytokines, signaling molecules that promote vascular inflammation and endothelial dysfunction, circulate at higher levels, and endothelial nitric oxide production, which is one of the primary mechanisms by which blood vessels maintain their elasticity and regulate their own tone, is reduced. Every one of these changes pushes blood pressure in the same direction, upward. And because they are all happening simultaneously, within a system that is already under the mechanical stress of elevated pressure, the effect is compounding. A study published in Hypertension demonstrated that even a single week of mild sleep restriction, reducing sleep from 8 hours to 6, produced measurable increases in both systolic and diastolic blood pressure in healthy adults with no pre-existing cardiovascular conditions. Not months of chronic deprivation. 1 week. Understanding that sleep lowers blood pressure is one thing. Understanding which specific elements of sleep quality are most directly implicated in cardiovascular regulation is considerably more useful, because it transforms the recommendation from a vague directive to sleep more into a precise set of adjustable variables. The first and most critical element is sleep duration. The cardiovascular research is consistent and dose-dependent in its findings. The relationship between sleep duration and blood pressure follows a curve, with risk rising on both ends. Below 7 hours, cardiovascular risk increases progressively with each hour of reduction. Above 9 hours in adults who are not ill, there is also an association with elevated risk, likely reflecting underlying health conditions rather than a causal effect of the sleep itself. The optimal window for cardiovascular protection in most of the population is 7 to 8 hours per night, and this is not a soft wellness guideline. It is a finding replicated across multiple large longitudinal studies involving hundreds of thousands of participants. The second element is sleep continuity. Fragmented sleep, characterized by frequent awakenings, even brief ones that are not consciously remembered, disrupts the architecture of sleep in ways that specifically impair cardiovascular repair. The nocturnal blood pressure dip is most pronounced and most sustained during slow-wave sleep, also called deep sleep or stage 3 non-REM sleep. When sleep is fragmented by noise, light, temperature discomfort, sleep-disordered breathing, or behavioral factors like late-night screen use, time spent in slow-wave sleep is reduced. Research published in the Journal of Clinical Sleep Medicine has shown that reduced slow-wave sleep is independently associated with impaired nocturnal blood pressure dipping, elevated morning blood pressure surge, and increased arterial stiffness, all of which are established cardiovascular risk markers. The third element, and the one most directly modifiable through behavioral intervention, is sleep onset timing and circadian alignment. The body's circadian clock, the internal biological timekeeper governed primarily by light exposure, regulates the timing of the nocturnal blood pressure dip as directly as it regulates the timing of sleep itself. When sleep is taken at times misaligned with the body's natural circadian phase, as happens with shift work, inconsistent sleep schedules, or habitual late-night light exposure, the nocturnal blood pressure dip is blunted or absent even when total sleep duration is adequate. A consistent sleep schedule, with regular sleep and wake times maintained even on weekends, is one of the most powerful interventions for restoring circadian alignment, and with it, normal nocturnal cardiovascular regulation. What happens in the 2 to 3 hours before sleep is not separate from the quality of the sleep itself. It is the preparation for it, and the cardiovascular evidence on specific pre-sleep behaviors is precise enough to warrant detailed examination. Light exposure in the evening is the single most powerful circadian disruptor in the modern environment. The photoreceptors in the retina that signal the brain's master clock are maximally sensitive to short wavelength blue light, precisely the spectrum emitted most intensely by smartphones, tablets, computer screens, and LED televisions. Evening exposure to this light spectrum suppresses melatonin production, delays sleep onset, and shifts the circadian phase in ways that blunt nocturnal blood pressure dipping. Research published in the Journal of Clinical Endocrinology and Metabolism has shown that melatonin itself has direct vasodilatory and blood pressure lowering effects, acting on receptors in the vascular smooth muscle to reduce peripheral resistance. Suppressing melatonin through evening light exposure is therefore not merely a sleep quality problem. It is a direct cardiovascular intervention in the wrong direction, taken every evening by the majority of the adult population. Evening sodium intake compounds this further. The kidneys do much of their blood pressure-related fluid regulation during the night, and meals high in sodium consumed in the hours before sleep impose a fluid retention load on a system that is attempting to recalibrate. Research has shown that high sodium evening meals are associated with blunted nocturnal blood pressure, dipping, and elevated morning blood pressure, independent of overall daily sodium intake. The timing of salt consumption, not just the quantity, has measurable cardiovascular consequences. Evening alcohol consumption deserves particular attention because its relationship with sleep and blood pressure is widely misunderstood. Alcohol is a sedative, and many people use it to facilitate sleep onset, experiencing it as relaxing and sleep-promoting. In biochemical reality, alcohol fragments sleep architecture in the second half of the night, suppresses slow-wave sleep, increases sympathetic nervous system activity during sleep, and is independently associated with blunted nocturnal blood pressure dipping. A study published in the European Heart Journal Digital Health found that even moderate alcohol consumption in the evening produced measurable reductions in heart rate variability during sleep, a marker of autonomic nervous system balance, and attenuated the normal overnight drop in blood pressure. The perception of better sleep following evening alcohol is a pharmacological illusion. The cardiovascular reality is the opposite. The practical question that all of this leads to is a direct one. Does deliberately improving sleep quality through structured behavioral intervention produce measurable reductions in blood pressure? And the answer, increasingly well supported by the research literature, is yes. A meta-analysis published in the journal Sleep Medicine Reviews, consolidating data from multiple intervention studies, found that sleep extension and sleep quality improvement in individuals with short or poor sleep produced clinically significant reductions in systolic blood pressure, with effect sizes comparable to moderate dietary sodium reduction. In individuals with established hypertension, improvements in sleep architecture were associated with improved nocturnal blood pressure dipping, reduced morning blood pressure surge, and in several studies, reduced requirements for antihypertensive medication over time. A particularly compelling study from the University of Alabama at Birmingham randomized adults with elevated blood pressure to a sleep extension intervention designed to increase sleep duration towards 7 to 8 hours, and found that over an 8-week period, systolic blood pressure fell by an average of 13 millimeters of mercury in the intervention group compared to controls. 13 millimeters. To place that in clinical context, the average reduction in systolic blood pressure produced by a single antihypertensive medication is typically between 8 and 12 millimeters of mercury. A behavioral sleep intervention, in other words, produced blood pressure reductions comparable to pharmacological treatment in a group of adults who had previously been sleeping fewer than 6.5 hours per night. This does not mean that sleep optimization replaces medication for those who need it. For individuals with established hypertension, medication adherence remains essential. But it does mean that sleep is a cardiovascular intervention of the first order, not a complementary wellness practice, not a supporting lifestyle factor, but a primary modifiable determinant of blood pressure that is systematically underutilized in clinical practice and almost entirely overlooked by patients managing their own cardiovascular risk. The translation of this evidence into behavior requires specificity, because the general recommendation to sleep better is approximately as actionable as the general recommendation to eat well. What the cardiovascular research supports, concretely, is the following. A consistent sleep and wake schedule maintained within 30 minutes of the same time every day, including weekends, is the highest leverage single behavioral change for circadian alignment and nocturnal blood pressure regulation. Consistency of timing matters more than any individual night's duration, because it is the regularity of the circadian signal that determines the depth and stability of the nocturnal dip. This is a finding that cuts directly against the common practice of sleeping insubstantially on weekends to compensate for weekday sleep debt, a pattern that disrupts circadian alignment and has been associated in research with what is now called social jet lag, a measurable shift in circadian phase that impairs nocturnal cardiovascular regulation independently of total sleep time. Eliminating screen light in the 90 minutes before sleep or using blue light filtering settings on devices, if elimination is not practical, directly addresses the melatonin suppression mechanism. The evidence supports dedicated blue light blocking glasses as a practical alternative for those who cannot avoid screens in the evening, with several studies demonstrating improved sleep architecture and melatonin levels in individuals using them consistently. The bedroom environment merits more attention than most people give it. Room temperature has a direct effect on sleep architecture. The body needs to reduce its core temperature to initiate and maintain deep sleep, and an overly warm sleeping environment impairs this thermoregulatory process, reducing time in slow-wave sleep and fragmenting sleep continuity. Research indicates that a bedroom temperature between 16 and 19 degrees Celsius supports optimal sleep architecture for most adults. Darkness and noise reduction follow the same logic. Each represents a potential source of cortical arousal that fragments sleep continuity and reduces slow-wave sleep time. For individuals who suspect their sleep is fragmented by breathing difficulties, characterized by snoring, gasping, frequent awakenings, non-restorative sleep, or excessive daytime fatigue, the possibility of obstructive sleep apnea warrants formal clinical assessment. Sleep apnea is one of the most common secondary causes of treatment-resistant hypertension, and it operates through precisely the mechanisms described throughout this script: repeated nocturnal sympathetic surges, cortisol elevation, suppression of slow-wave sleep, and complete abolition of the normal nocturnal blood pressure dip. Treatment of sleep apnea with continuous positive airway pressure therapy has been shown in multiple studies to produce significant reductions in blood pressure, particularly nocturnal blood pressure, and in some cases reduces or eliminates the need for antihypertensive medication in affected individuals. What makes this night habit so important and so underappreciated is not any single mechanism in isolation. It is the convergence. Sleep, when it is consistent, sufficient, and architecturally intact, simultaneously suppresses sympathetic nervous system activity, normalizes cortisol, supports melatonin-mediated vasodilation, enables endothelial repair, restores renin-angiotensin regulation, and produces the nocturnal blood pressure dip that is one of the most powerful independent markers of long-term cardiovascular health that medicine has identified. No single pharmaceutical agent achieves all of these things simultaneously. No dietary intervention produces effects across this many converging pathways. Sleep does, every night, automatically, provided the conditions for it are established and protected. The reason this does not occupy a more central place in how cardiovascular risk is managed in clinical consultations, in public health messaging, in the way people think about their own heart health, is partly the same reason that blood pressure itself is so dangerous. The consequences are silent and delayed. The damage from a decade of 6-hour nights does not announce itself. It accumulates in arterial walls and ventricular muscle and kidney tissue, invisibly, until the clinical event makes it visible. The people I see in the emergency department at 2 a.m, in hypertensive crisis, in heart failure, in the aftermath of a preventable stroke, they did not choose this path. They simply were not told, clearly and specifically enough, that the hours between 11 at night and 7 in the morning were not neutral time for their cardiovascular system. They were not told that what happened to their blood pressure while they slept was as clinically significant as what it read in the clinic. They were not told that the screen they scrolled before sleep, the alcohol they used to wind down, the inconsistent weekend lie-ins, the warm and noisy bedroom, that each of these was a measurable intervention on a biological system that was trying every single night to repair the damage that the day had done. Now you know. The night habit that lowers blood pressure naturally is not a supplement or a protocol or a technique. It is the commitment to making sleep a genuine clinical priority with the same rigor, the same consistency, and the same understanding of the underlying biology that you would bring to any other aspect of managing your cardiovascular health. 7 to 8 hours, consistent timing, a dark, cool, quiet room, no screens in the 90 minutes prior, no alcohol as a sleep aid. And if you are waking unrefreshed despite adequate time in bed, a conversation with your doctor about whether obstructive sleep apnea may be silently dismantling the cardiovascular repair your body is trying every night to perform. The biology is working for you every time you sleep. The question is simply whether you are giving it the conditions it needs to do its job.